Review prostate MR cases online. Answer each case according to our structured pro forma answer page. And then get immediate feedback against a radical prostatectomy. 300 cases, track your progress, earn CME points. Visit mripro.io.
At least 7:30 on the eastern seaboard of Australia. So I think we'll get going. So welcome everybody. We've got actually quite a large contingent of participants who are joining us tonight. Australia, New Zealand mainly, but we've actually got I think it's something like 24 countries represented for this multidisciplinary meeting. So it's exciting. So welcome to you all, and thanks for joining us. I really hope that you find this hour's session useful. So I'd like to introduce our panel of experts who have very kindly joined us tonight and offering their time and expertise. John Yaxley from Brisbane, another urologist. Hi, John. We've got Morgan Pokorny from Auckland, New Zealand. Again, another urologist. Hi there, Morgan.
Hey, everyone. Thanks for having me, Jeremy.
Absolute pleasure. Thanks for joining us. And our original group, I suppose, is myself, but also Richard O'Sullivan, who you won't be able to see today, but you'll be able to hear his voice, and he'll be explaining all the MRIs. So Richard is a really quite very well known, certainly in Melbourne and beyond, for his expertise in prostate MRI. And we've been working together for many years now. So say good day, Richard.
Thanks for having me, Jeremy. It looks good.
Yeah, that's great. And finally, Andrew Ryan is our expert uropathologist who works for Tissue Path here in Melbourne. And you'll be seeing some pretty extraordinary representations of histology throughout this session. So Andrew, thanks for joining us. Our MDM actually started, I reckon, back in 2014. And it was really based just on prostate MRIs when they were first being used. And we found that the feedback that we were getting from using pathology on the MRIs was just so helpful for everybody who turned up. So we thought that, you know, now that everyone's pretty savvy with using Zoom, that it would be worthwhile at least taking it online and seeing if other people found it useful as well. So I hope you do. I would like to just thank the MRI Pro team. So thanks Alex in particular for organising tonight. For transparency, I'm one of the co-founders of MRI Pro. And I just wanted to show people a very short video just explaining what it is. So I'll just try and get that up and I'll share my screen in just a moment. Just bear with me. So I'll just show you a very short video so you can get a handle of what we've created.
Review prostate MR cases online. Answer each case according to our structured pro forma answer page. And then get immediate feedback against a radical prostatectomy. 300 cases, track your progress, earn CME points. Visit mripro.io.
All right, just so that's really just a very brief explanation as to what our online program is all about. Now back to the multidisciplinary meeting that we're getting on tonight. But first, before we get stuck into the cases, just a little bit of housekeeping. The point of this is to be as interactive as possible. Now we've got, looks like we're up to 73 participants now, so obviously there's going to be a limitation on that. But we do have a Q&A function that you'll see on Zoom. So if you do have any burning questions as we're going through this, please don't hesitate to type them in. And Morgan, if you're happy to just keep an eye on the Q&A as they come in, and then we can hopefully address the questions either verbally or by text as they come in. We'll try and address some of them, but obviously we probably won't get to all of them. The other thing I just wanted to let everyone know is we plan to record tonight's session so that if your colleagues miss it, they can still catch it later on. We're going to post it online onto the MRI Pro website. And of course, you can even speed it up if you do it that way. So you'll be able to listen to us in double time and in half the time. So it might be a bit of an advantage. All right. So let's get stuck into some cases. We'll move first to case one. There's probably been quite a few people who have joined us since I started talking. So welcome everybody to this prostate MRI MDM. So I'm just going to share my screen again in a moment, and we'll see the first case come up in just a sec. All right. So this is our first case for tonight, and we've deliberately created these cases to have plenty of discussion points, so that you're not going to find any particularly straightforward cases. There's going to be plenty of controversies, I hope. All right, so we've got a 70-year-old guy whose PSA came in at 6.1. We repeated it and it was 6.2 with a free to total PSA ratio of 31%, which is actually within normal range. Prostate health index was also taken, and we'll come back to that in a minute, and was 46, which is right on the borderline of what might be considered normal. So putting all that together, this patient underwent an MRI. So I'll stop sharing my screen, Richard, and I'll get you to show us the MRI. And just while you're doing that, Richard,
can you see that?
Oh, you've got it already, very quickly. Terrific.
Sorry,
All
did
right.
you want to say something, Jeremy?
No, it's all right. I'll come back to the blood test in a moment, but please go ahead and take us through.
Okay, so this is how I look at them. There's multiplanar T2s. The top left-hand corner is the sagittal, then the axial, and the two top right-hand corners, the one I'm moving at the moment is the ADC. The one to the right of that is the high B value diffusion imaging. That's at a B value of 1400. Then this one in the left and the right-hand corner is the sagittal ADC, and the sagittal high B value is the one next to that. The one in the middle at the top is the DCE, so it's a color enhanced image that's laid over a T2 image, and the one below that is the raw partition data from a particular time point. Okay, so this is quite a small prostate, about 20 centimeters in size. If you look at the axial T2s first, we see transition zone here, and it's really diffuse decreased intensity seen throughout the peripheral zone. Not really anywhere that's focally abnormal that's convincing. It's a bit more dense, it's a bit more darker at the base than is elsewhere. If we look at the high B value is where most of the information is. If we start on we go from base to apex in the top right-hand corner, I'm scrolling through that now. This is the seminal vesicles here. You've got to remember that if we look at the ADC, the bad things are black, and on the high B value, the bad things are white. So there's nothing black or white in the high B value here. As we go more inferiorly, you can see at the right base, there's a focal area of restricted diffusion. So if we look at that on the high B value, it measures about 1.4 centimeters. If we look at the ADC, that's a low ADC, so it's black and white, that's bad. And then if we look at the sagittal images, we can see the same lesion at the base with high B value restricted diffusion and reduced ADC. So that's a PIRADS 4 lesion, but there's a second lesion we can see. If we look here in the sagittal high B value, it's probably the easiest. You can see a focal lesion that is measured about 0.4 centimeters in size in the anterior right apex. Mm-hmm. We can see it here on the ADC, a focal area of decreased intensity in the axials, and it's almost hidden on both the colour and on the T2A images. That first lesion I showed you does demonstrate focal contrast enhancement, which we can see here. So I think there's two lesions, a PIRADS 4 lesion with that extra capsular extension of the right apex, and a smaller 0.4 centimeter PIRADS 4 lesion anteriorly at the right apex.
Okay. Before we move on to any histology, any comments on the imaging so far from the other panelists?
Well, Richard, we just got a question about just asking for a brief
sorry, you're breaking up, Morgan.
Seconds on that.
Sorry, say that again.
Richard, there was a question from one of the attendees just asking to explain a bit more about how you interpret the DWI.
So the DWI is really the central, most important sequence we have. It's really two different parts. The ADC, which is the attenuation, the apparent diffusion image, which the abnormality is shown as black. It's really a marker of increased cell density.
So that's in your third column there, Richard.
That's this one here I'm scrolling through now. So it's darker on ADC here. Yep. And the lesion on your right is that we acquire at the same time it's at a high B value, and the B value is 1400. So this is true restricted diffusion, and this is corrected restricted diffusion. The mnemonic I use is that if it's black on ADC and white on high B value, it's abnormal.
Yeah. But I guess
do you think that's clear enough, Morgan?
No, I think that's great, Richard. Just to be clear, those third and fourth panels there that you've got are both diffusion-weighted imaging
in the axial
series,
and sagittal plane.
And then you've got sagittal down the bottom there, and the third and fourth. Yep. Okay. Whereas on your far left, they're the T2s. You've swapped them though. You've got sagittal on top and axial down the bottom. And then the second column is dynamic contrast enhancement.
Yes.
Yep. Terrific. Okay. Thanks for that. Now, obviously, based on the strength of this MRI, thanks, Richard, this patient underwent a biopsy, and we do a transperineal biopsy typically, and so that's what we had. Now, Andrew, are you free there with your pathology?
You're muted, Andrea.
Yeah, I'm not anymore. Are you seeing that pathology now?
Yes. Yes.
So this is these are from November 2016, and there's extensive involvement of the different sites, mainly by 3+3, 3+4, low percentage pattern 4. But the target biopsies are presumably from that posterior region, 3+4, 30%, with really quite extensive involvement of the cause as well, up to 10 millimetres, and also noted ductal type morphology. Okay.
Any comments on the biopsy? You can see that we've done targeted plus template, which is our routine, and it's certainly what the guidelines would suggest. No comments on that. Okay, so based on that, this patient then went ahead to. Do you mind just stop sharing? Thanks, Andrew, and I'll just go back to the actual case. So this patient went on to have a robotic-assisted laparoscopic radical prostatectomy. Now, I performed a bilateral nerve sparing on this patient, but no pelvic lymph node dissection. Just going back to the pathology, Andrew.
Yes.
There was, if I remember correctly, so you had some ductal carcinoma found on the biopsy result.
Yeah. Yeah, so that's something that we're probably getting better. This is back in 2016. We're probably getting better at identifying ductal morphology and probably getting a better idea of the significance of it as well. And that goes for intraductal carcinoma as well. Probably we're talking about 4 or 5 years ago, and although we were mentioning it from a morphological standpoint, maybe we weren't actually understanding the significance of it clinically as much as we do now.
John, can I ask you, if you saw ductal carcinoma on your biopsy, would that make you think differently about anything?
Well, it's probably less likely I'm treated with radiotherapy. We've done a lot of radiotherapy and brachytherapy, and they tend to be, in my personal experience, radio resistant. They don't do as well as you'd expect with radiotherapy, so I'd be more likely to operate. I suppose from my personal point of view, the question is, would that necessitate a node dissection? Looking at the primary pattern 3 and the PSA values, I wouldn't. These days in 2020, it'd be easier because I do a PET PSMA scan, although we might talk about it later, but ductal carcinoma doesn't necessarily mean it's PSMA avid. But providing the PET PSMA was negative, then we've got some good data that's coming out to show that the risk of positive node dissection would be low.
Yeah. Okay. Thanks for that. Andrew, do you want to show the pathology and also sort of take us through how you represent it?
Yep. So we'll just go here. Sorry about the back to front. We used to present these left to right, so to speak. So we've flipped these around. These are older ones now. But just before presenting the actual pathological findings for this case, I thought I'd just take one step of how we develop these images. We develop these images for every radical prostatectomy. and they're meant as a diagrammatic representation of where we're seeing cancer. You'll also note here that I've got orange and black, and they represent, we represent these as index tumour and other foci, which are the black foci. So just very briefly, when we have our prostate, we're serial transverse sections from superior to inferior, and then the apex and the base slices, then additionally sliced in the parasagittal plane. So we see these slices here will sometimes be sliced in the midline or into quadrants. So this is an example of a prostate that has been cut with these parasagittal sections of the base and the apex, and then the intact transverse slices will then subsequently be either sliced in the midline or into quadrants. So then we go back to what I've shown here, and these are developed after we've looked at the slides. So we mark the slides as we're looking at them and show where tumour is, and then we rescan the slides, the histological slides, and reconstruct them into the anatomical kind of appearance that you see here. So that's, you're going to see these for all of the radical prostatectomy cases. And as I say, we develop these for all the patients. We certainly get the feedback from the urologist that these are useful both from a clinical perspective as well as from a patient perspective.
Yeah, I mean, these representations for me, Andrew, have just been absolutely superb, particularly, well, one, as you say, for potential decision making. We'll come to that in a minute, such as nerve sparing, for example, potentially, in terms of future patients, knowing what the MRI looks like compared to the final specimen. But just generally, in terms of getting a handle on what the MRI is showing us versus what is actually present, I think these are invaluable. You've got the verbal report on this particular case as well, Andrew? Or?
Yeah. So I'll go. So really, what I'm showing here is this correlate with what Richard was showing, with really quite an extensive bilateral apical to lower mid tumour, and then other foci probably relating to his second lesion that he described. So I just did have just a couple of histos just to show that while there was a lot of Acinar type tumour, this was what we probably hit when we were talking about the ductal. So this is a low power of that quadrant, or that, parasagittal slice. And this on low power is showing ductal morphology, which again, just Acinar morphology, ductal morphology. We won't go through what actually they are, but just to kind of demonstrate that we do see things that are histologically different. So that's look, I've looked back on this. This wasn't reported by me. I think that that's undergraded pattern 4. I think pattern 4 was a little bit higher in this, probably closer to what was described in the original biopsy. But there was, the tumour was otherwise organ confined, and margins were clear.
Thank you. So when we do go back and compare to that MRI that you showed us before, Richard, what would you say about the volume comparison? I mean, we've seen how much volume there is on the actual specimen. You don't necessarily have to show us the images if it's...
Yeah.
But if it's
Well,
yeah.
I think this is pretty typical, particularly of larger lesions, is that MRI underestimates the extent of the lesion. Often significantly. You can see here on the actual high B value at the apex, it's really only on one side, not both sides, and the same in the sagittal image. That's very common. So I think you should think about when you're biopsying, on MR, you're biopsying the core of the lesion. We're not necessarily getting all of the lesion. We do underestimate the disease.
Yep. Morgan, would you say that's a pretty common finding in your experience?
Just repeat the question. I was just typing some answers to Q&As. Sorry.
No, it was really just to basically comparing the volume of lesion on MRI versus the actual volume of the cancer in reality on the specimen. Richard was basically just commenting that it's almost invariably larger than what it looks like on the MRI. Yes,
no, I fully agree. So, I mean, Yax and I have published a couple of papers with our pathologists from Brisbane, and routinely the MRI lesion is smaller than the true tumour volume on pathology. Which is probably why our targeted biopsy results are so good, because you can still miss with a few millimetres and still hit the lesion because it's always bigger than what you see.
Yep. Okay. All right. Now, just moving on with this particular case. So his initial post-op PSA was undetectable, but at 12 months post-op, it rose up to 0.2. So this kind of moves into a different territory, but just in terms of clinically, John, if you saw this patient, what would you do next?
He's hit the trigger to rescan. We rescan somewhere between 0.2 and 0.5. I'd probably rescan him now. He's got a fast doubling time, 0.2 within a year. He's suspecting systemic disease. Pickup rate's about 20%.
When you say rescan, what are you talking about?
I'd do a PET PSMA scan. I'd be worried that looking at the histo slide that Andrew showed, most of that high volume tumour was ductal. So, you know, I'd be worried about whether we'd pick that up. And of course, I'd be obviously worried about metastatic disease with a predominantly ductal higher grade cancer. The reason I'd scan now is, you know, he's young, he's got a lot of life expectancy, he's failed early. So if I was going to do salvage treatment, I'd probably treat him earlier rather than late.
Yeah. Now, that actually brings up another point, because this particular patient, you'll recall, didn't have a staging PSMA PET in the first place. Mm. So it kind of begs the question, you know, when you do get a recurrence and you kind of want to know really whether that primary tumour was PSMA avid in the first place. Are you finding that you're doing more and more upfront or staging PSMA PETs partly because of that, or?
No. So everybody, pretty much everybody has had an MRI before radical for ages, like your institution. But we've pretty much everyone gets a PET PSMA scan now preoperatively, unless they're low volume 3+4. We used to initially it was 4+3 and above, but we're now doing it for anyone with 3+4 for a couple of reasons. One, and we may talk about this later, but there's some SUV diagnostics for us if you've got someone who you think may be suitable for active surveillance and they've got a very intensely PSMA avid lesion. That's a real red flag that he's not an appropriate candidate, number one. Number two, it's nice to know they're PSMA avid beforehand, because if the primary tumour is not avid, then that may have some implications for high-risk cancerous, whether you need a node dissection, because then you can't trust the PSMA. If you haven't got an avid tumour, how do you know there's no metastasis? So they're probably the two major reasons we do it now.
Yep. Okay. So just to finish off this particular case, which I shall do now. So this patient did have a PSMA PET. I won't show it because it was negative, so there's nothing to see. And we decided to actually go on and do salvage radiotherapy, even though we couldn't see anything. But fortunately, his PSA 2.5 years later is still undetectable. So
I would say on this one is that while PET is clearly the first test to be performed, if you think it may be a local recurrence, MR is better.
Yeah.
Yeah, I agree.
We can talk to that now. Why not?
Well, there is a case further on. I think we can talk about that if you want to.
Yeah,
when we get to that.
Actually, you're right. If we get to it, we can perhaps talk a bit more about that because that'll be quite controversial, I think.
I'll also probably say now with Richard, we'll talk about that. Particularly in ductal, if you're worried about ductal, MRI is probably even better for that particular group of people for local recurrence too. But we'll talk about that later.
All right, let's move on to case 2. So this is a 63-year-old man who has a PSA of 7.3. It's repeated, it's about the same, and so goes on to have an MRI.
Just give me 1 sec. You want to take this? Oh yeah, okay.
Just while you're doing that, Richard, just going back to that, there's one other point out of that last case. I'd be interested to know, John and Morgan, you might recall that I mentioned that the patient had a prostate health index. Now, in my practice at least, I would typically do a total PSA, of course, and then a repeat with a Frida total. Are you guys using any other tumour markers, such as PHI, or just the Frida total? Morgan?
No, unfortunately, New Zealand, pretty.
Morgs, you're frozen a bit, so I might take it just for a sec. So the area under the curve is better for MRI than PHI, so I don't use it. The time I do it is that if your PSA is going up in discordance with a negative MRI, particularly if there's a family history. That's when I do a PHI. So if your PHI is in the high risk zone, elevating PSA despite an MRI, that's really something I definitely biopsy despite a normal MRI. And then you throw in other figures like PSA density and the family history, and that will influence you. But a high PHI, negative MRI, that's probably the only time I'd use it, but routinely.
Yeah. Okay. Sorry about that, Morgan. Your audio was cutting in and out.
Do you want to have a look at the images for case 2 now?
Please do, Richard. Yep.
Okay, so again, same setup, sagittal T2s, top left-hand corner, axial T2s, axial ADC, top right-hand corner, high B value, axial, and then the sagittal on the bottom right. Now, this is a tough case, this one. Not a lot to see. Prostate volume about 40 cc, nothing to see on the T2s.
Mm-hmm.
And really, the only thing that looks a little bit abnormal is this tiny area of restricted diffusion.
Mm-hmm.
Here. So in the, it's very subtle. You can see the sagittal area, it's over about 0.5 centimetres. Very difficult to visualise on the, at the right base on the axial T2 images, and no contrast. It does, however, demonstrate some focal contrast enhancement. This is a subtracted image in the bottom, in the bottom left-hand corner.
Yep.
So I would call that somewhere between a PI-RADS 3 and a PI-RADS 4.
I think so. Now, this patient's had 2 sets of MRIs. Richard, is this the first one or the second?
This is the one that was performed in 2016. Is that right?
That's okay. I think they were pretty similar anyway.
Yeah.
So that's all right. But I think
it didn't change from previously. It was done a year before.
But I think the original report was a PI-RADS 2, I think.
Yeah. Well, this is a very subtle lesion here, and it's a tough area. So I think it's PI-RADS 3, but I'm not sure.
Yep. No, so, I mean, this is really to demonstrate that, prostate MRIs are not always obvious by any means. So on the strength of, I should say, rather than avoid a biopsy in this patient, this was done at a time where we hadn't really got to a stage where we were that confident with avoiding biopsies with negative MRIs. So I actually went ahead and did an initial biopsy. That might be the second one, I think, Andrew.
Yeah, I've got a negative biopsy in
Would have been
September 2015.
Yeah, there you go.
There we go. That's it there.
There you go. Yeah, so that first biopsy, and you can see the PSA there is 10, so it's pretty decent, and that's with a 50 cc prostate. So pretty substantial PSA density there, but thorough transperineal biopsy, 6 sectors. You can see, I think, about 3 or 4 cores from each sector, no sign of cancer. So for this patient, we've done a biopsy, it came back negatives, and so we basically just watched him and got PSAs every 6 months or so. And if you just perhaps unshare there, and I'll just see if I can share mine again, Andrew. So that was that initial transperineal biopsy. Now, 12 months later, his PSA has gone up. Now it's 13.8. And we talked about that prostate health index before at being 77. Now, again, this was at a time where MRI was relatively new. And so I was using prostate health index a fair bit at that time, much less so probably along the lines of John now. But we repeated the MRI. You've already heard that the repeat MRI actually didn't show much different. But we repeated the biopsy, and perhaps, Andrew, if you can, I'll just stop sharing, if you can show us that.
So that's the repeat biopsy. With involvement of the right mid and right posterior base. Interestingly, we didn't have a lot of luck with the anterior cores, right and left anterior mid apical cores, anterior mid and posterior. So the tumour that we saw is this acinotype, mostly well differentiated, well formed glands, but there are these more complex glands here at a minor percent of the overall tumour. So 3 + 4, 10%, located in the right posterior base.
Right posterior base, yep, okay. All right. We then got a PSMA PET, and I'll just share my screen with you so you can see what that looks like. So you should be able to see that, I hope. Obviously, you can ignore all of the uptake, the normal uptake in the salivary and lacrimal glands, liver, spleen, kidneys, bowel, etc. You can see some tracer in the urine in the bladder, but obviously there is a substantial uptake on the patient's right side at the base of the prostate. So, you know, pretty discordant really with what we're seeing on the MRI. So anyway, he went on and had a robotic prostatectomy. So perhaps, Andrew, if you can show us the pathology, and then we might go back and have a look at the MRI and just see if we can see how that differs so much from the PSMA PET.
Yeah, well, it's fascinating once we go and have a look at this. So there is a definite tumour at that right posterior base that extends, and we represent this. The yellow is extraprostatic extension, and the blue is seminal vesicle involvement. So there's extraprostatic extension all along that posterolateral base with seminal vesicle involvement on the right-hand side. But interestingly, the index tumour is actually an anterior tumour on the same side, extending really the full length of the tumour from the lower mid all the way up to the base. And so that'll be interesting to go back. This is the low power, this is a quadrant, and this is the right anterolateral quadrant, and this is the index tumour here. A lot of that has asthma type differentiation with well-formed glands, but this is the pattern 4 that we saw within the tumour as well. And that's the thing that bumped it up over the other peripheral zone tumours. So this ended up being, I think, graded as 4+3, up to 70% of that peripheral. This is the appearance, probably more like what we were seeing on the biopsies. There is some complexity in here, but this is the base of the seminal vesicles with seminal vesicle involvement. But still, that index tumour is in the transition zone. So that was, 4+3, 60%, whereas the other tumour with 3+4 and 3+3 in other areas as well.
Thank you. So, Richard, what do you make of this? I mean, you've shown us the MRI where you've said that it's barely visible, if at all, whereas the PSMA PET, it was very hot.
We do see this. Sorry, I've just gone to the. This is the right page. So this is essentially not present on the MR. I mean, it's a maybe lesion at the right base, which we've seen here, which is underestimated. The transition zone lesion we're not seeing at all. So the way I think about PSMA PET and MR is they are complementary tests. I think each one picks up about 90% of high-grade tumour, plus or minus. If you do the two together, it gets closer to 95% of pickup rate. But they are complementary. Some of the ones that we don't see on MR, we see on PET, and vice versa. So I think it's a great addition to have a PSMA PET for intraprostatic disease in the patient which you are concerned about. Yep.
Okay. I think the other thing that worries me a little bit about this case is that, you know, even despite a pretty thorough transperineal biopsy, we didn't actually catch the index tumour. We got part of the cancer around the back. So I'd normally do a kind of a modified Guy's template or a Ginsberg template, which tries to maximise the peripheral zone, even as it curls right around the anterior horn. I'd be interested to know, Morgan and John, what kind of biopsy template, assuming you still do templates, or whether you just do targeted biopsies now. Morgan, do you want to try your audio?
Yeah, can you hear me okay now?
Yep.
Yeah, I do targeted transperineal with the MRI up on my laptop next to me, and then I take systematic template biopsies from the rest of the gland, peripheral zone mainly, but then I take at least 4 from the transition zone on both sides anteriorly if I'm concerned.
Yeah.
But I always sample the peripheral zone well, just for helping with the nerve spare later on, so that I know confidently that there's nothing there if I'm doing a full nerve spare.
So you'll deliberately take some cores from the posterior peripheral zone bilaterally just to make sure that they're clear of cancer, is that right?
Yeah, I'll do that routinely, even if I'm doing targeted cores, although I do trust the MRI. And I think if the MRI is very clean, I don't spend a lot of time taking a lot of extra cores from the other normal side.
How about you, John?
Yeah, so I still do both target and template. I'm more likely, probably over the last 5 years, to include transitional zone biopsies. I normally do minimum of 3 each side if it looks normal on MRI. And the only time, probably the only time I'd ever just do target biopsies only if you've got a big whopping PIRADS 5 tumour, the ADC value is 500, you've got an SUV max of 12, and I know I'm going to do a radical prostatectomy. If you just take a few cores to get the diagnosis, the operation's a lot easier, particularly if you're nerves through the other side. But apart from that, I pretty much always do target and template.
Yeah, yeah, very good. All right.
Richard, I was just going to ask Richard if he could show us the T2 axial for that last case on a full screen.
Not sure.
The axial T2s.
Not sure if
Yeah.
you full
Can you
screen.
see that? So the transition zone looks the same there as it does there.
We're not seeing that, Richard.
I can't see that lesion.
Okay. All right. Well,
Okay, thanks.
we might keep going. We've got a few more cases to get through, but we will. We won't go over time because people have got other things to do. So let's move on to case 3. And let's put that up. All right, so we've got a slightly younger guy now, 57, PSA 5.7, which again, repeated, still around the same. Now this case was from a pre-MRI era. So he went straight to biopsy and that was done as a transperineal biopsy. Do you have the result of that, Andrew? Can't hear you, Andrew.
Okay, sorry, that's the February 2013. That's the one you're after.
Yeah.
So that's 3+3, small focus of 3+3 in the left posterior.
Yep. Okay, thank you. So this patient went on to active surveillance as a result of that. And 12 months later, PSA unchanged. This is a period where MRI was coming in, and as I'm sure most of you be familiar, MRIs sort of come in the back door in terms of initially being used, when either for active surveillance or people who had perhaps a negative transrectal biopsy. As we know now, it's used up front for all comers. But anyway, went on to have an MRI. So Richard, if you can show us that.
Okay.
Case 3.
Can you see that?
Yep.
So these are the sagittal T2s. This is a 50 cc gland, moderate BPH, minor linear decrease in signal intensity in the peripheral zone. If we go to the high B value in the top right-hand corner, you can see there's a focal area of restricted diffusion here measuring just on 0.8 of a centimetre. You can see it's decreased density on ADC here. That'll have an ADC of about 800. And if you go back to the T2, you can see this area of homogeneous decreased signal intensity anteriorly, probably going into the anterior fibrous stroma, and here it is on the sagittals. So the ADC, I've got that as measured as 0.8 centimetres. I think that's a PIRADS 4 lesion in the anterior transition zone.
Mm-hmm. Okay. Any other comments on the MRI from others? It's a pretty small lesion, and it's
I wonder, Richard, if you could just put it on one window or two windows next to the ADC, just so that the attendees can have a good look at it, please. Yeah, that's nice.
That's good.
Because that's a very important point. Anterior lesions make up quite a chunk of prostate cancer. We know now, probably 30%.
So that's the axial here. You can see the ADC. This is different to anywhere else. This is typical BPH, a well-defined black margin, and this is not. This is homogeneous decreased density, and this is the high B value that corresponds to it.
Yeah. I just, I mean, I've obviously missed this on my template transperineal biopsy. I can't imagine what the chances would be of getting it, of hitting it on a transrectal biopsy. I think it'd be pretty slim, I suspect, with an anterior lesion like that. All right. So anyway, as a result of this MRI, we repeated the biopsy. You got that, Andrew?
Yep. So his second load of the biopsies with a target lesion left anterior midline, again showed small foci of 3+3 scattered throughout the gland. Target biopsy is 3+4 up to 9 millimeters in multiple cores. So you've done a good job of hitting at that time.
So now I didn't do any staging on this patient because there was such a low percentage of pattern 4. So I went on and did a radical prostatectomy.
And that's our picture here, and it correlates so beautifully this time around with the MRI. Index tumours in this anterior transition zone, extending from lower mid up to the base, with other smaller little foci that they're the ones that we were seeing in the other the other biopsy sites. So that's just the low power of it. This is the BPH nodules that we were seeing. So this on low power is a BPH nodule. I'm not sure whether you see my hand where I'm pointing.
Yes.
And here's the tumour here, and it's still a low-grade tumour, predominantly well-formed glands, but there are small little areas with complex glands. So that's graded as 3+4, 10%. Is organ confined and margins clear.
Thanks, Andrew.
I would say that 3+3 cancer we don't see on MR.
Yep. As a rule. Yep.
There's got to be a lot of it and very dense.
Yeah. I mean, even this was interesting that we managed to pick it up. I mean, it was quite visible, as you've shown us, Richard, albeit small, because even then there's, not a whole lot of pattern 4 present. But I think the sort of take home from this case for me was that, in years gone by, this would be the sort of poor bugger who would have had maybe 3 or 4 sets of transrectal biopsies, each of them either showing nothing or the, the tiny amount of Gleason 6 that's going to be incidental and would have been missed. But the other aspect, and this is a bit of controversy, I suppose, nowadays, that we have such good imaging. I mean, you can see that doesn't always correlate perfectly, but that was a beautiful correlation between imaging and pathology. John, what do you think of, especially anteriorly as well? What are your thoughts on focal therapy?
Yeah, so if he came to see me wanting focal therapy, how old was he again, Jeremy? He was, say, 60 something?
57. 57,
yeah, he's still young. It depends. I mean, he's certainly suitable for focal therapy. You'll be active surveillance of the minor 3+3 in the peripheral zone. We do nanoknife IRE, irreversible electroporation, and it's a way. In that area, it's not going to stop you doing a radical prostatectomy down the track. It's not going to hurt your sphincter, your posterior margins. I suppose for me, the other controversial thing, one is focal therapy. And if we said to Andrew, if there's less than 5% pattern 4 and there's no cribriform malignancy, would you even consider this guy to continue on active surveillance, particularly if he's young and wants to maintain potency for a bit longer until he gets definitive treatment? So that's probably a controversial area too. And there'd be a lot of people who would put this guy in active surveillance, providing the pattern 4 is low and there's no cribriform malignancy. He hasn't changed his PSA in 12 months, and you can monitor the lesion. So for that guy personally, I do a PET scan, make sure it's not really hot with his SUV max. But yeah, look, I wouldn't be completely horrified at active surveillance of that, and I wouldn't be horrified either at focal therapy for that. Not that I'm trying to advocate internationally focal therapies for everybody, but there's certainly a group that it's good for.
Yeah. What? Thanks, John. What do you think, Morgan? What's happening in that sphere in New Zealand? Excuse me.
Well, we do have IRE here available as well, and certainly I think it's an option for men that are not fit for surgery, perhaps, or that have a very well circumscribed lesion and negative biopsies elsewhere in the gland. And like John says, it doesn't stop you doing more aggressive treatment down the track. There's a few options. All of them are early on in their sort of natural history, so we don't know the long-term outcomes. I had one IRE failure that I was sent away in Brisbane who got a very nasty Gleason 9 at the edge of the IRE treatment zone.
Yeah. Okay.
You sort of...
Oh, sorry, Morgan, you've frozen, so I'm just asking over the top of you, hopefully.
Further on to what Andrew was saying, and Richard, anterior Gleason 6 tumours are a real entity, and they can look quite aggressive, and you often worry that you may not have biopsied it properly, but I think our targeting is very good, and we just have to be watching it.
Yep. I was going to ask how you, if you're planning with focal therapy, how do you take into account what we've seen here today in a couple of the examples of the size of the lesion? Now, if you're seeing something on MRI, especially one that's actually got relatively low percentage pattern 4, how do you plan for your focal therapy if you are going to do that?
So we take a wider margin. I think the early data on, say, IRE was a 10% infield failure at 12 months. That's the biopsy data, and that was really focal therapy. I actually make sure there's a reasonable margin around the tumour. We have a treatment zone of 2 centimetres. So anything that's really outside, anything's bigger than 2 centimetres, certainly anything bigger than 2.5, I probably wouldn't treat with focal therapy, because you've got to do almost a double treatment, and that's almost counterintuitive. So providing it fits within that margin, then our infield treatments, I personally haven't had a positive treatment yet, but that's just probably because I need to do more. But I know the big centres that have done more than 100 or 200 there, they've got an initial infield treatment failure of about 10%. But that's dropped down as they've actually expanded the margin around the tumour.
Thanks, John. We've just got a couple of questions coming through, just to sort of hark back a little bit on biopsies. Morgan, you mentioned basically that you do cognitive biopsies because you've got your MRI screen right next to you on your laptop. How about you, John? What are you doing in terms of that?
Absolutely. I actually published with Morgan. We looked at the MRI guided biopsies in bore versus our cognitive target biopsies, and they're exactly the same, looking at diagnosis of not only significant, all cancers, but also significant cancers. And those numbers was high. I think it was about 594 men in that series. So.
So I'm not sure if you guys work in a number of different hospitals, but I certainly do in Melbourne. And in terms of my biopsies, it really depends on what equipment is available in the hospital. So there's one hospital where I'll use fusion biopsy using a robotic device. But in other hospitals where they don't have that equipment, I'll just use a brachytherapy grid. At least I certainly have up till now, and continuing to do that in the near future. And I'll do cognitive. And like you said, Morgan, I'll literally just open my laptop with the MRI on a trolley right next to where I'm doing the biopsy. Now, having said that, obviously, there's a fair bit of noise now about, particularly overseas, about doing transperineal biopsies under local anaesthetic, whether you can use a little stabilising device or not. Have you guys got any thoughts on that?
Well, I'm just sort of in the throes of trying that, because we've got a fusion device in public that we'd like to use to do transperineal in clinic. We're currently just getting a favour over the last 6 months under GA. But we've done a few cases in theatre with a little bit of light sedation and transperineal, and it's the Artemis device, and it's good. It's very good for targeting, but if the patient coughs or moves slightly, your whole registration is gone and you've got to start again.
Yeah,
so,
right.
Local is all well and good, but you've got a very cooperative patient and you need really good infiltration of that very sensitive skin. So in Australia, we had it sort of quite nice because you could just do a GA, quick procedure in theatre. Costs in New Zealand are certainly more of an issue. So we want to do things as smartly but as cheaply as possible.
Yeah. All right, let's move on. This might be our final case because I can see time's getting away from us. So if we can move on to case 4, I will get that up. Hang on just a moment. All right, so we've got a younger guy now, 49 years old, PSA 5.2, free to total PSA ratio only 5%. Interesting family history, not of prostate cancer, but his father actually had breast cancer, which is obviously pretty rare, but happens. An MRI. Richard. Case 4.
Okay, this is a prostate of about 20 cc, relatively small prostate, Again, homogeneous decrease in intensity in the peripheral zone on the axial T2s. If we look at the high B value here, you can see there's a focal area of restricted diffusion over about a centimetre posteriorly at the right mid-prostate. You can see here it's of decreased intensity on the ADC. I'm always a little bit nervous adjacent to the rectum, whether that's an artefact. And if you look at the axial DCE, you can't see an enhancing component. Now, this is a summation image of about 4 or 5 images together and then put on a T2. So I always look at what I call the partition or the raw data, which is this one in the bottom, where it's just the subtracted image, and you can see it focally enhances corresponding to the abnormality on the ADC and the high B value. So I've gone from being reasonably confident to very confident that's a PIRADS 4 at the right base, right mid-prostate.
Now, Richard, this again, this was originally reported as a negative scan. What do you think the pitfall is?
Well, I think there are 2 pitfalls. This patient has got a reasonable amount of bowel gas. We actually give everybody a bowel preparation now. We give them a microlax. Everybody gets that unless they object strongly. So air is a problem for us. The other pitfall is normally we'll see it, this is the axial high B value, you can't see it on the sagittals, which is unusual. Usually you'll see it on both. So I think that's the pitfall, a bit too much gas and not seeing on the other images and not looking at the partition images.
And just a bit more on the practicality. So you give not bowel prep per se, but an enema, just a microlax, so a small enema. And in terms of the machine you're using, it's 3 Tesla?
Yeah, so we use a body coil with 3 Tesla, no indirectal coil. Yeah. This is another, again, an older case. So we used to bring the patient in 15 minutes before the study, put the IV in and get going. And now we bring the patient in an hour before the study to allow them to use the microlax. So it does add a bit, it makes they stay in our department for longer than they did before, but it's definitely worth it.
And then how long are they in the actual scanner for?
It's quite a long scan. Because we do 2-plane diffusion wave imaging, we also do some imaging of the pelvis. The actual scanning time is just over half an hour. That's even with a 3T machine, 64-channel body, 64-channel coil, high gradients. It's as state out as you can get, and if we drop the time any further, we just don't get the results. So you've got to put the time in.
Yeah. Okay, thank you. So with this particular patient, as we discussed, the initial report came back as negative, but I remember reviewing this MRI with the patient, and when the patient came back to discuss it, and because of the PSA density, I really wanted to have a closer look, and that's when, in discussion with Richard, we realised that perhaps there was that lesion there. So, on the strength of that, we then went ahead and did a transperineal biopsy. I think Andrew, you should have that.
Yeah, I do, but I thought I did. But it looks as though I jumped straight to the that's our previous case, and then I jumped straight to the radical. So I can tell you that the report showed right posterior 3 + 14%, 6 millimetres, and a targeted right posterior peripheral zone tumour of 3 + 4, 40% of 2 millimetres.
Okay, so again, based on that, went ahead with a robotic prostatectomy, and I think you've got the...
And that I do have, yes. So that's the diagram. It shows beautiful, really does show very nicely what Richard's shown us in that right posterior, mid-posterior peripheral zone. That's the low power of it, again, with this circles. This is actually shows nicely how we do it. We're circling these tumours, and that's how we develop those diagrammatic pictures afterwards. And a lot of well-formed glands as well as complex glands, 3 + 4, 30%, I think, overall, confined to the prostate and margins clear.
I think it does highlight the interaction between the clinician and the radiologist. It's really imperative. If you're clinically concerned, it just makes us look a bit harder in different spots. It's really helpful for us.
Yeah, no, I agree, Richard. And even as urologists, if we see a report that's negative, but we're really suspicious, then, you know, if we're familiar with reading prostate MRI, then it's worth us ourselves also going back over the imaging, I reckon, if we can't necessarily get in touch with the radiologist. But of course, ideally, we want to have that discussion. The thing that really tipped me off for this guy, I mean, there is a family history we'll talk about in a minute, but PSA density, I think, is the real lesson, is that if you get a negative MRI, but you've got a strong clinical suspicion, and that might be because your PSA density is more than 20%, for example, it's really worth going back and have a look. And sometimes you won't even find a lesion on the imaging, but if you do a biopsy when the PSA density is greater than 20%, even if the MRI is negative, you'll find significant cancer. Any thoughts on that, John?
Yeah, I agree. I think PSA density 0.2 or 20% I'd be very concerned about. Again, similar, if you've got the negative MRI and the PSA is slowly going up and the PSA density goes above 0.15, it's rare that I don't biopsy them anyway, to be honest.
Yep, yep. This family history or the father having breast cancer, does that make you think potentially that he might be a BRCA gene carrier? And if so, how do you do BRCA testing, or when does it come into your clinical practice?
I mean, I personally don't. I mean, unless there's a cluster of families, a father and son, you know, maybe. But you know, if you've got uncles, and I've got a patient where there's five sons and the father, and 4 sons and the father have got prostate cancer, and the other son saying, "Well, John, when are you taking it out?" So obviously BRCA gene, and that would be significant. And then obviously there's the medico-legal ramifications for their children if they test BRCA positive and things that go with that.
Morgan, do you do any genetic testing?
No, look, I must admit that I don't, but I do think about it, and it'd be nice to get some more data or clarity on which people are, or which groups are the right ones to check for it.
Yeah.
But I think, yeah, practically, again, it's difficult and costly.
Yep.
I think you'd find that if you've got a father, like probably if his father had breast cancer, nothing would have been done when he had it back then. But I'd imagine that younger men or men having breast cancer now would be investigated for BRCA. So maybe that isn't the stimulus that, you know, even though it wasn't done originally, that maybe, especially at the age of 49.
Yeah.
But that would be, you know, you guys refer these guys onto familial cancer clinics and things. They're very clever at these kind of decisions.
We do, but in honesty, you know, it's very rare that a bit like what John was saying, pretty rare that we actually do it. So it's something that I think we need to think about a lot more when you do have patients with a significant family history. Now, I don't think we're going to have time for any more cases tonight because we're almost on 8:30, but we do have many more cases to discuss. So I suspect that one day, perhaps in the near future, if people are interested, we may well get an opportunity to discuss some more. So what I would like to do as 8:30 approaches is thank everybody who's on the panel. I really appreciate you all coming together in the evening to share your time, your expertise. It's just been fantastic. Really enjoyed your commentary on these cases. I hope we can do it again one day. And I'd also like to thank all the participants who are out there. I do hope it's been useful for you. We will send you out a survey so you can give us some feedback. Please be candid. Let us know what works, what doesn't. And hopefully, if it's useful enough, we'll be doing some more in the future soon. So thanks again, everybody. If there's people out there who do want to go away and practice reading prostate MRI, then as mentioned, MRI Pro is available online, so you can just Google it and see what you think there. All right. Thanks, everybody.
Thanks for organising it, Jeremy. Well done.
Yeah, thank you.
Thanks, Jeremy.
Thank you. Thanks for having me.
Absolute pleasure. Thanks, everybody, and we'll see you all soon.